So I hope you've been enjoying the whole virtual round process so far. I apologize for some of the delays, but I want to make sure that you have enough time to go over the material and discuss it with your groups. I feel like you're going to learn a lot more from your groups than you would just listening to me and discussing it with me. So, looking at some of the work that you guys have done so far, I definitely see a lot of progress, and I'm very proud of all of you. The fact that you're able to dissect a case that is not even complete yet and come up with a good understanding and a good reasoning why you would choose one diagnosis over the other shows that you guys have grown quite a lot since we started this program. So I'm excited to see what you guys think of the cases coming up and the cases we're going to do after that. And if you have any suggestions on how to improve this program or things that you want to see in the program, please let me know, because more than anything, this is your program. I want you to have a say and shape it in a way that you think that's going to be most beneficial. And I'm open to suggestions. And then if there's things outside of this program that you want me to do or you want to learn about, just let me know as well. I can put up a sign up sheet or a form on the classrooms where you can fill out things you want to hear from me or learn from me. So having said that, let's go through vitals. So vitals are probably one of the more important parts of a history and physical. They're called vitals because they actually are vital. It's our way of seeing, is a patient stable or not. It's one of the factors, but it's a great way of getting a snapshot into the overall condition of the patient. Irrespective of what they have, if your vitals are off, you have to be very careful with that patient and have be on your toes with them, because the last thing you want is to have a patient that looks okay but their vitals are horrible and crappy, and they tank, and they come back and say, well, didn't you see those vitals? So let's go through the normal set of vitals, and then we're going to talk about what I guess vital signs you would see in each of the different causes of chest pain we've discussed. So in this video, we're going to be only talking about adults, but I do realize that some of you are budding pediatricians, and so we can talk a little bit about the newborn and the age 3 to 5 vitals. Honestly, the vitals are going to vary as you grow older. So if you look at the newborn vitals, they're generally a lot higher than the adults over here. And as you get older, they start to trend more towards the adult level. And so if you know the newborn and kind of know more or less the progression, if you don't have it completely memorized, you can guess more or less what the normal vitals are. When you are taking care of kids, though, it's going to be very important to keep an eye on the vitals. But just to go through it really quickly, the adult blood pressure usually ranges, the normal is 120 over 80, but the range is going to be anywhere between 90 to 120 for the systolic and 60 to 90 diastolic. The heart rate is going to be 60 to 100. Respiratory rate, which is how fast you're breathing, is going to be 16 to 20. The normal temperature is about 98.6, which is 37 degrees Celsius. And the normal O2 sat is 95 to 100. I mentioned before in previous videos that your O2 sat should honestly be anywhere between like 97 to 99% if you're a healthy young person. Once you start trending a little bit lower, there's a lot of different reasons for it, but if they're coming in for a respiratory problem, you're going to want to keep an eye on them, because for the most part, we should not be trending onto the lower sides if we have healthy lungs and if we're generally healthy. And the temperature and the O2 sat, more or less, it's going to be the same for the newborns and the people aged 3 to 5. The newborn blood pressure is going to range anywhere between 75 to 100 systolic and 50 to 70 diastolic. The heart rate is actually pretty fast. The first time I saw a newborn and I saw their heart going at 150, I was like, is there something wrong? But no, that's in the normal range for them. And then the respiratory rate is going to be similar to the heart rate. They're going to breathe faster than the adults are going to breathe. And so the rate's usually 30 to 50. And as we grow older, our blood pressure is going to go a bit higher. 3 to 5, we get to about 110 systolic, 80 diastolic. Same with the heart rate. We go from 80 to 120 when the normal adult's about 100. And then 20 to 30 when the normal adult's about 20. But again, the temperature and the O2 sat are going to be the same. So now that we've kind of discussed a little bit about the peds, I'm going to disregard this for the rest of this. Kind because we're going to be going through some of the pathology of chest pain, and some of that doesn't really it doesn't really apply to pediatrics. Like, you're not going to have a newborn with a heart attack, hopefully. So we're going to focus on just the adults. If anybody is interested in peds, let me know. I can put some pediatric cases up too, and we can discuss that. All right, so this is a, I guess, general chart of what your vitals can look like in each of these disease states here. But you have to remember that this is all, it all lives on a spectrum. So if you have mild disease, well, for instance, like if you have a heart attack within a small territory, you can have normal vitals. But so this is not 100%, but this is what I've seen the most. And I looked up some of these that I wasn't 100% sure, and this is what I have noted from most of the sources. So let's start with angina. So angina, again, is that chest pain that you get that worsens with exercise and improves with rest. So a lot of times your blood pressure could be normal or it could be elevated. The elevated blood pressure sometimes just because that patient has high blood pressure to begin with. So that's something to think about. The heart rate can be normal or it can be a little bit elevated. If the patient is actively in pain, or there's an active process going on, your sympathetic nervous system, so that's the part of your nervous system that prepares you for the fight or flight response, activates, and you usually will get an elevated heart rate, an elevated respiratory rate, and an elevated blood pressure. So if you think of a disease process that would make you like panic or would make you be put into that fight or flight response, you would typically have an elevated BP, an elevated heart rate, and sometimes an elevated respiratory rate, not all the time. So something to keep in mind. So that's why with angina, you can have an elevated heart rate, you can have an elevated respiratory rate. This isn't an infectious process, so your temperature is usually going to be normal, and then your oxygen saturation. With angina, you're not really compromising the heart's ability to pump, so that's usually normal. Now let's talk about a myocardial infarction. So in an MI, it's going to be similar to angina where you're going to usually have an elevated blood pressure. It's not all the time. I've seen patients that had an ongoing MI and their blood pressure was in the normal range. But whenever we have blood pressure in the low range, you want to worry because that tells us that your heart isn't able to actually push out the blood and a large territory might have been affected. So keep an eye out for the low blood pressure. Heart rate is generally up. Again, you have that sympathetic response, that fight or flight response. Same with the respiratory rate. And then it's not an infectious process. So your temp is usually normal and your O2 sat is usually normal. So the oxygen saturation, though, again, if you have an MI and you have a large territory and your blood pressure is going down and you're not able to really push that blood out, you can have a low oxygen saturation. And when you get to that point, that we're talking about cardiogenic shock, where the heart is basically stunned and it can't function like it's supposed to. Next is pericarditis. And with pericarditis, your blood pressure can be normal, but it can also be a little bit elevated. If your heart's beating faster, like we said in previous videos, your cardiac output equals cardiac output equals heart rate times stroke volume. And so if your heart rate is going up and your stroke volume is staying the same, the volume that you're putting out, your cardiac output is going to go up. And so if you're putting more blood into your vessels, you can have a bit of a higher blood pressure. So you can have a little bit of an elevated blood pressure with pericarditis. You will usually have an elevated heart rate because the pericardium being inflamed and irritated is going to, the way that I think of it is it's also irritating to the heart itself. And so you're going to have more activation of those muscles and you're going to generally beat faster. So if you're in a lot of pain, you can have an elevated respiratory rate. But the times that I've seen pericarditis, it was low normal. It was if it was elevated, it was on like the 20s, like 22. So it wasn't super high. Temp is usually normal. O2 sat's usually normal. If you have an infectious process that caused a pericarditis, a lot of times that infectious process had already passed, and this is the sequela of that infection. And so I don't typically see a lot of fever with pericarditis. Now, aortic dissection, a lot of times when I've seen aortic dissection, it's been that blood pressure has been pretty elevated. And it's usually very, very elevated. I have yet to see a aortic dissection with a low blood pressure, but when you do have a low blood pressure, a lot of times that is because you have a rupture, or you created such a big third space, a space in between that aorta, that potential space here, that a lot of blood is going into this side. And so with aortic dissection, we typically see elevated blood pressure, but if you have low blood pressure, just like with the MI, you want to worry about failure of your circulatory system. Your heart rate's going to be up for similar reasons. Well, actually, for a few reasons. One, it's painful, and so you have that sympathetic response. But two, same thing with the cardiac output equals stroke volume times heart rate. And so if your stroke volume is down because you're spilling blood into that potential space here, then to maintain your cardiac output, your body's going to want to increase your heart rate. So that's why you're going to have an elevated heart rate. And then the same with the respiratory rate. If it's particularly painful, you can have an elevated respiratory rate. These two are going to generally be normal. The O2 sat will be low if you are having low blood pressure. Anytime you have a low O2 saturation, a lot of times it's kind of towards that end of the disease state, and the patients are usually in a more serious place. Now, these up here where your cardiac causes of chest pain, the blue over here is going to be your pulmonary causes. These are your abdominal causes, your GI causes, and these are the miscellaneous. Each of these colors refer to a separate video that I put out, so refer to that video to get a little bit more in depth with the process going on for each of these diseases. So with a pneumonia, a lot of times your blood pressure is going to be normal. Your heart rate can be elevated when you have sepsis, but if it's just a straight up pneumonia, it's the patient's not septic yet. They're not very sick. They can have a normal heart rate. The respiratory rate, a lot of times I actually see it normal. They're not really struggling to breathe, and when they are struggling to breathe, that's already the disease process progressing, and they're in a more critical state. But when they come into the hospital, it's kind of 50-50 for me. I've seen them with normal respiratory rate and some with an elevated respiratory rate. The temperature is traditionally going to be elevated. It's not 100% consistent. I've seen patients with a pneumonia that have no temperature at all, but usually when we're thinking infectious processes, the temp is going to be elevated. Now, you always want to ask a patient if they have taken medications right before they came and saw you. So if they say that they took Tylenol right before they came in, or an hour or so before they came in, that can actually decrease an elevated temperature. And so they'll come in looking better than they actually are because they have the Tylenol on board. Same thing with ibuprofen or any of those other non-steroidal anti-inflammatories. So just keep that in mind. If you're thinking of pneumonia but the temperature is normal, ask them if they took anything for a fever. Now the oxygen saturation, if it's not too bad, if it's kind of that early stage of pneumonia, a lot of times it's going to be normal. But when they come into the hospital, I usually see, and we're going to admit them, I usually see the O2 sat on the lower side. Now a pneumothorax is the blood pressure is typically normal from what I've seen. If you have a low blood pressure, you start to have a compromise in your heart's ability to pump out, and so we're thinking kind of a tension pneumo at that point. The heart rate is generally going to be a bit elevated, and the respiratory rate is going to be elevated as well. And the way that I think of it is your heart is trying to compensate against lungs that aren't really working like they're supposed to. So they're not inflated as much, so your heart's trying to get more blood to the area. You're trying to breathe in more air to oxygenate that blood as best as possible, because if you have a large territory of lung that's not working, then you're gonna have a hard time supplying enough oxygen to the rest of your body. The temperature is typically normal. It's not an infectious process, so that's usually not an issue. The O2 saturation, if it's a big pneumothorax, you're going to have a low O2 sat. Otherwise, you can have a normal O2 sat. Now, with pulmonary embolisms, when I usually see them, they're not incredibly large pulmonary embolisms. So the blood pressure, it can be a little bit elevated, or it's going to be normal. Now, when do you have a low blood pressure? Kind of like the previous examples, when you have a big clot here or a more severe disease process, you're going to have your blood pressure on the lower side. That kind of signals that something major is going on. So with a pulmonary embolism, you can't push that blood past this blood clot. And so if no blood is going to the lungs, then no blood is coming back from the lungs into the heart. And so if that's not happening, you're not able to push blood out. And if you can't push blood out, then you have a failure of your pump system. And so your blood pressure is going to be low. And that is a very ominous sign that something is very wrong with if you are thinking of PE. And so those patients you want to evaluate immediately and see if we need to push clot busting medications like TPA. I've had one patient where they had a large enough pulmonary embolism that we had to push TPA, and they were feeling fine, felt dizzy, fainted, blood pressure tanked, and it was a very large PE. So in a pulmonary embolism, like I've told you guys many times, the heart rate is going to be elevated. You have that sinus tachycardia, and that's that number one sign that we see on EKG as well. The respiratory rate is generally a bit elevated, although with small ones it can be a bit on the normal side. Not an infectious process, so your temp is normal, and then the O2 sat is going to be generally lower than what we would expect for that patient. So it can either be on the lower side of normal for a very young, a healthy person, or it can be like in the 90, like the low 90s, like 90 to 91 to 92, somewhere in there. If it's below 90, then they have a pretty large territory that's not working, or they have underlying lung disease. Now, on to the abdominal causes of chest pain. So, GERD, PUD, and pancreatitis. GERD and PUD are generally the same. Your vitals should be pretty normal all the way throughout. It's not an acute process going on that can potentially kill you. If a patient is in severe pain, you're gonna have that sympathetic response, kind of like what we talked about before. But I don't think I've ever seen that. And with PUD, like we've talked in previous videos about, if you have a lesion that erodes into the mucosa and it erodes all the way down, that ulcer erodes all the way down, and you compromise a blood vessel that's there and you start to bleed into your stomach or wherever that is, then you can, and you're just pouring blood in here, your blood pressure can actually drop because you're bleeding into your stomach. So that's the only time I would say that we have any changes in the vitals. But at that point, I mean, it's not. I mean, I guess the underlying condition is PUD, but what we're more worried about is a gastrointestinal bleed. So I wouldn't say it necessarily qualifies for PUD because there's another process going on. Now, with pancreatitis, that's that inflammation of the pancreas, which is that organ in the belly that helps you digest food and produces insulin. So when you have inflammation of that, your blood pressure can be a little elevated if you are in a lot of pain, but usually I will see kind of on the normal side. If you've been vomiting a lot and your blood pressure and your volume is overall down, you can have a lower blood pressure. It is pretty painful, and your volume is down, so your heart's going to try to compensate to maintain that cardiac output. So stroke volume. So your heart rate's going to go up to maintain the cardiac output. So your heart rate can be a bit elevated. Your respiratory rate is going to generally be normal unless you're in a lot of pain and you're kind of breathing fast because of the pain. The temp is going to be normal unless you have an infection going on. And I've seen patients with pancreatitis that had kind of a low normal, a low level of elevated temp, like 100.2. And you always want to be wary of those patients and keep an eye on them to make sure that they don't have an infection. Now, pancreatitis isn't really affecting your lungs per se. There are conditions where you can have ARDS with pancreatitis, but that's kind of out of the scope of what we're talking about here. So typically your O2 saturation is going to be normal. Costochondritis is inflammation of the lining, the connection of your ribs to your sternum, and so there's no acute process going on there, so everything should be normal with costochondritis. And lastly, we have anxiety. So anxiety, it can mimic a lot of different things, and so Your blood pressure, though, is typically going to be normal with anxiety. When you have an anxiety or a panic attack, you are going to be having that sympathetic response. So your heart rate, your respiratory rate are both going to generally be elevated. And so, if somebody comes in with a panic attack, they can have an elevated heart rate, they can have an elevated respiratory rate. The temp is going to be normal, the O2 sat is going to be normal because there's nothing really going on with the heart or with the lungs that's going to compromise their overall health. So, anxiety, they can have these two things. And so, if we think about, if a patient comes in with elevated heart rate, elevated respiratory rate, we can say, oh, shoot, are they having a pulmonary embolism? Because both of these are going to be elevated. They're having some chest pain, so you're going to have to evaluate how certain are you that they're having a pulmonary embolism. If they have kind of that inciting event before where they just took a test or, whatever it is, and their O2 saturation looks good, then, and they don't have any like blood swelling, they don't have any risk factors of having a pulmonary embolism, they're generally young and there's not any other issues, then, well, we can kind of say it's anxiety, but we have to make sure that there's nothing else going on with that patient. Remember, with anxiety, costochondritis, all these other different diseases that aren't very serious, you never want to just say, oh, it's that disease process, because you want to make sure that the patient is safe first and foremost. So I hope this was helpful to you, seeing all the vitals laid out like this. If it was, let me know. I can maybe do this for the abdominal pain cases and the other cases we do. I think knowing what the typical vitals picture is very helpful, because you can kind of tell, is this just the natural disease process where you're going to have for a PE, you're going to have elevated heart rate, elevated respiratory rate, or is it something like a MI where you're having a low blood pressure and you start to have a low O2 sat, and it's like, shoot, is our heart failing? And we're not pumping out any blood. So think about the reason why each of these things are the way they are. Try not to memorize it. You don't have to memorize it for a class. Just try to understand as best you can why is it that each of these disease processes give you these vitals. If you have any questions, let me know. And again, if you want to support this effort, subscribe to the channel, like the video, share it to whoever you think is going to benefit from it, and give me any suggestions about what you want to learn about in this class.